Hello and welcome to the virtual town hall meeting on coronavirus 2019. My name is Michelle Mata and I will be your host for today's webinar. Today's webinar is being recorded and will be available later today. An announcement will be made on the COVID-19 website and via email. Before we get started, we want to share some reminders to help you stay engaged in this webinar. So let's go ahead and take a look at those. For this webinar, we will be using the chat feature, and some of you have been using that now, and we appreciate it. This can be found by hovering towards the top of your screen. If you have a question or concern at any time during the webinar, please use the chat feature to communicate with the host and panelists. We'll address questions during the webinar or at the end of the webinar. Now, let's begin with our first panelist, Dr. Michael Charlton.
I'm Mike Charlton. This is Jason Bowling and Tom Patterson to my right.
Hi, good afternoon. We'll start by talking about some of the fundamentals about COVID-19 and what we know so far. So it's important to recognize that we're still learning more about this virus and the different things that go along with this disease. COVID-19 is the name of the disease, so there are some prior acronyms that were being used before, but this is the new official name for the disease process, and that is an acronym that stands for Coronavirus Disease 2019. So with emerging infections moving forward, they're trying to find names of the disease process that don't pick a location or a source, so they have a more general name so they can be used moving forward and related as necessary. This disease is caused by a new coronavirus, SARS-CoV-2. And you can tell by the name that obviously it has some similarities to SARS, and we'll talk a little bit more about that. But an important distinction is that coronaviruses are actually a large family of viruses that cause respiratory infections. There are several known coronaviruses that cause upper respiratory infections in humans. They cause the common cold in all of us. And we know about these, and that's important to recognize because it can lead to some confusion because there are respiratory virus panels that exist right now that detect these coronaviruses. And actually the one at University Health System detects 4 of these coronaviruses. Really important to recognize that none of these coronaviruses on that respiratory virus panel are the coronaviruses that cause COVID-19. None of these are the SARS-CoV-2. There is not cross-reactivity with those viruses, and that's been tested. So how is COVID-19 different? So how is it different from these known coronaviruses? So the known coronaviruses we talked about that cause the common cold. So most people have had the common cold. On average, people have colds about 3 to 4 times a year. Children have more of those, about 5 to 6 times a year, and they have pretty mild symptoms. However, this is a little bit different in that SARS-CoV-2, which causes COVID-19, is more similar to SARS coronavirus and MERS coronavirus than these other coronaviruses that cause the common cold. So SARS stands for Severe Acute Respiratory Syndrome, and MERS stands for Middle East Respiratory Syndrome. And so you can tell by those names, one of the reasons why they moved to this new naming system to call it COVID-19, because those names are not entirely helpful. So SARS-CoV-2 is very similar to SARS. Both SARS and MERS diseases started off as animal coronaviruses that moved to humans and then spread. So SARS is believed, bats are believed to be the reservoir for all of these coronaviruses actually. In SARS, it began in bats, and then it moved to a civet cat, and then it moved to people, and then began person-to-person spread. Similarly, MERS began in bats as the reservoir, then moved to camels, and then moved into people for person-to-person spread. COVID-19 also believed to start off in bats, and then it's moved to an intermediary animal, and that's not been identified at this point. There's ongoing research into that so that they can identify the source to try and prevent further transmission from the source. But at this point, what we're dealing with is person-to-person transmission. So again, very similar. SARS and MERS both cause more severe disease than the other common coronaviruses that I mentioned. And so COVID-19, the concern is, would have the same issues. What we're seeing now with the data that's been collected and being reported out of China where this first began is that COVID-19 causes severe disease in roughly 15 to 20% of patients. And so there is some more severe disease than we generally see with those common coronaviruses. But fortunately, we're seeing it is in 15 to 20%, which is less than what we saw with SARS and MERS. The other 80 to 85% of people that have documented COVID-19 seem to have more mild to moderate disease. So how is this spreading person to person? Mainly by large respiratory droplets, and that generally happens when people cough and sneeze. They expel large amounts of large respiratory droplets that can travel about up to 6 feet. So the issue that the main mechanism of transmission is somebody is standing within 6 feet of somebody else that coughs or sneezes, expels these respiratory droplets, and they breathe it in. Now there's probably also a component that if you cough or sneeze and you have droplets that land on surfaces that are then touched by another person and then they touch their face, either their eyes or their nose or mouth or mucous membranes, they could transmit the disease that way and become infected. However, this is thought to probably play a much lesser role than the large respiratory droplets from coughing and sneezing. Now, one of the challenges is this is a new virus. This is a novel virus, and so people don't have pre-existing immunity. And so if you do get exposed, what we're seeing with the rate of spread throughout the world is that the risk of spread is pretty high if you do get exposed. But again, it's by being within that 6-foot radius of somebody that's coughing or sneezing that's infected. So what are the symptoms? How do we diagnose this? So the incubation period, in general, most people that are exposed to this virus will have an incubation period on average about 5 to 7 days. So that means 5 to 7 days after they've inhaled some of these droplets with this SARS-CoV-2 virus in it, they start developing the signs and symptoms of COVID-19 disease. Now, the incubation period can last up to 14 days, and that was seen, some of this is based on the knowledge that we have from prior epidemics with SARS and MERS. And so 14 days seems to be the limit of this incubation period, and that's why this 14-day window is really being used for a lot of the discussions about people being in isolation or in quarantine, because you really want to have that quarantine period last for the entire incubation period. But again, most people will start to have symptoms and signs within 5 to 7 days of exposure. The most common symptoms, so fever by far is the most common sign. Cough and shortness of breath, so involvement of the lower respiratory tract is secondary. We are seeing less of the upper respiratory symptoms with this, the runny nose and congestion that we think about with the cold, than we see normally with our common cold symptoms or even with influenza virus. And then some people that have been infected with COVID-19 have had fatigue and myalgias, which is something non-specific. We see this with the flu as well. In general,
You might want to explain what myalgias mean.
so myalgias, to clarify, myalgias mean muscle aches. So when we talk about myalgias, when people have flu, they say their muscles ache all over, or they may feel sore, like they had exercise, even if they haven't exercised, and it's not just one muscle group, it's their entire body just feels really worn out and sore muscles everywhere. So we see that with influenza. This can be seen with COVID-19 as well. So important to recognize that there's a lot of non-specific symptoms that people have that really overlap with a lot of the symptoms that we see with influenza, which we still are seeing transmitted right now. And so there are a lot of respiratory infections kind of circulating right now that have similar symptoms that are not COVID-19, which gets to this real challenge. How do we make a diagnosis? So really one of the most helpful things at this point is a clinical history of exposure. And so we're following on a day-to-day basis where we're seeing transmission and confirmed cases of COVID-19, because that gives us a better understanding of if somebody might be at risk of exposure to COVID-19 or not. Right now, fortunately, in San Antonio, we're not seeing any community transmission, but we're continuing to monitor that closely, because if we were to see community transmission, then we might have to have some increased suspicion for COVID-19. But at this point, we're not seeing any documented confirmed cases of community transmission. There is a lab test that's done. It is a swab. They're doing a swab, both are of the throat. One goes through the nose and one goes through the mouth to the back of the throat, and then it's sent to the public health lab for PCR testing. I will say that at this point, all lab testing is coordinated with the health department and the CDC, and so it has to meet their criteria to be tested. Healthcare providers do not have access to this test. All of this testing is coordinated with the health department, who then sends it to the CDC lab at this point. Moving forward, there are plans to have testing available at the health department, but again, that will be controlled by the health department, and healthcare providers in the clinics do not have access to this test. So how do we prevent people from getting infected, and what treatments are available? So we should use the same strategies that we should be using right now anyway. We're still in influenza season. We're still seeing influenza transmission and new cases. We need to use these same strategies. One of the most helpful things that people can do is to clean their hands frequently. You can use either soap or water, and you need to wash your hands for a minimum of 20 seconds to make sure that you cover all surfaces of the hand in between your fingers. You can also use the alcohol-based hand rub, again, making sure that you cover all surfaces of the hands in between the fingers. Both soap and water and alcohol-based hand rub are equally effective against this COVID-19, this SARS-CoV-2. Both work well, they just need to be done frequently. Good respiratory etiquette, which means covering your cough. If you cough or sneeze, it needs to be done into either the crook of your arm or your sleeve, or you need to cover your mouth or nose with a tissue, which you then throw away, and then perform hand hygiene. Avoid touching your face. I know that this has made the news, and they've showed clips of people talking about this and touching their face. I'm trying not to do that right now. I will say that on average, when people aren't thinking about it, people will touch their face about 3 to 4 times an hour. So this happens frequently. It's really important not to touch your face with unwashed hands. And so again, if you're doing frequent hand hygiene, you're going to protect yourself even if you accidentally touch your face. And so important to think about. If you're touching a high-touch surface, you need to think about hand hygiene before you might accidentally touch your face. Avoiding sick people. So if you know that there's People that are ill should try and avoid contact. Again, being within that 6-foot radius potentially puts you at a risk of an exposure. Staying home if you're sick, it's a way that we can help avoiding sick people, right? And so if people are sick, they need to stay home. If people are having fever and cough, not feeling well, they don't need to show up to work or to wherever they may be in the community. Cleaning and disinfecting frequently touched surfaces often. So we talked about the major method of transmission being by cough with large droplets. A smaller mechanism, but an important one, is if you have droplets on a surface and someone else touches that surface. And so disinfecting frequently touched surfaces is important. Doorknobs, bed rails in the hospital setting, doorknobs everywhere. Standard disinfectants are highly effective against this. So if you're using an EPA-registered disinfectant, that will work. This virus is easily disinfected and cleaned. The surfaces just have to be disinfected. So unfortunately at this time, there are no vaccines or treatments available. There's ongoing work and research towards a vaccine and also research onto what treatments might be available. But at this time, there is not a vaccine and there are no treatments available.
Before we go off this slide, Jason, one of the things I like to mention, since this is a group of people from Texas, one way to think about hand hygiene is imagine yourself and you had just cut fresh jalapenos, right? And you are cutting jalapenos with your bare hands and you have to change your contacts, right? Imagine the level of hand hygiene that you would achieve in order to put your fingers in your eyes. The level of hygiene that Dr. Bowling is mentioning is essentially similar to that. We don't just want to run our hands under the water and sort of glaze over it. Yeah. We want to be very thorough and deliberate about it. And so that just to try to help kind of put some bookends around it.
Yes, absolutely. So thank you. That's an excellent example. And so that's exactly right. So we got to be very careful with hand hygiene. The other aspect of that is handshaking itself. I grew up in Texas and we all shake hands. But really at this point, we should look at other ways of greeting people. And so either a fist bump or an elbow bump or just waving at somebody, probably better things to do right now at this time to avoid hand-to-hand contact, because this is another potentially contaminated surface. We talk about high-touch surfaces in the environment, but the palms of your hands obviously touch everything. And so if someone else, you can speak to your own hand hygiene, but you can't speak to the hand hygiene of somebody else. So
for sure.
I completely agree with that. So this is a rapidly evolving situation. It's a fluid and dynamic situation. We're following information updates as they're provided. Those are changing sometimes on a daily basis. There are several different examples of global map trackers. We have some of those on the SharePoint site. We have some links to ways that you can track information about the number of cases. There are ongoing meetings in the institution to discuss how we continue operations in light of the news that we're getting and the data we give about this COVID-19 disease. Here in San Antonio, we were introduced to COVID-19 a bit earlier because we have hosted now 2 groups of people that were evacuated, 2 groups of people that were evacuated from sites outside the United States. So initially it was a group of people that were evacuated from Wuhan City in China that were brought to Lackland Air Force Base, and then the second group was on the Diamond Princess cruise ship that was brought back and monitored during their quarantine period. And that second cohort has been released as of earlier this week, March 3rd. So now we've moved from that phase to really this phase 2 where we're looking for community transmission. And so that's the current state that we're at in San Antonio. These are the case numbers that were current as of last night. They've already changed some more. Again, this is or I guess this was this morning. They continue to change. So we're at over 100,000 cases at this point. Total confirmed deaths at 3,400. And so if you look at the case fatality rate, it's about 3.4%. Now, I will mention with that currently most of these confirmed cases are cases that are being confirmed in people that are being admitted to the hospital. Based on the availability of testing, we're not doing a lot of widespread testing in the outpatient setting, and we know that about 80 to 85% of people that have COVID-19 probably have mild to moderate disease. And so there's a lot of discussion and estimates that this case fatality rate over time may decrease. But clearly, there are fatalities with this, and so we have to be careful. Most of the people that get into more trouble with this and have more severe disease, either respiratory failure or in worst case scenarios death, are older patients, people that are 65 and older, or they have underlying comorbidities, other medical problems such as chronic heart disease like congestive heart failure, chronic lung disease like COPD or emphysema, or other things like uncontrolled diabetes. Currently the number of cases in the United States is 233. That number has gone up a little bit. In cases in Texas, we have 16 cases, and so 11 of those are from the patients we talked about that were evacuated back, but we now have 5 cases in Texas, one of those in Fort Bend County, the other 4 in Harris County, all of those in the Houston area, all 5 of those people were on the same travel group. And so that is not believed to be community transmission, but they were all in the same travel, so they had exposure during their travel. We do not have any cases unrelated to the quarantine patients at Lackland and Bexar County this time. There's not been any documented community transmission in San Antonio or in Texas at this time. So what should you do if you're sick? So we talked about the signs and symptoms so that you can recognize that. Really important things to be aware of, everybody needs to be aware of, are where there's activity of COVID-19. Because you need to know about that for travel purposes and planning. You need to be talking with your supervisor if you're planning any travel. There's going to be more to come on that. If you are ill and you have concerns that you may have been exposed, you need to contact somebody. So don't come to work and then tell people that you're ill, but calling and letting people know so appropriate plans can be made. Again, treatment is supportive care and hospitalization if necessary. Most people, again, 80 to 85% are probably going to have more mild to moderate disease and won't require hospitalization. They're probably going to have symptoms more consistent with a cold, maybe a bad cold. There is a website that we have, a UT Health San Antonio website for information that we're going to update and have access to information so you can continue to see what's going on with this. We want to continue to communicate. And you can see on the infographic there, they highlight the main symptoms: fever, cough, and shortness of breath.
Okay. Tom, was there anything that you want to add before we go into some of the
No, I think
policy-related issues?
it's fine for you to really go into our kind of policies and issues, and then be thinking of your questions. We'll take all the questions together at the end.
Yeah, so thank you, Tom and Jason, for that. If you do have some questions, there is a chat box there, and all you have to do is type those in. Michelle it will help us to kind of ferret those out to the different panelists, and we'll try our best to get those back to you. And so let's just go into the next slide, and we'll talk about kind of what the impact that the COVID-19 is having both here at the Health Science Center, but also really institutes of higher education across the United States. So just yesterday, you should have received a message from Dr. Henrich that essentially restricts, very significantly restricts travel, particularly international travel. And so when Dr. Bowling was giving his comments about some of the risk factors, hopefully you got a flavor for the importance of travel history and how strongly associated that's been with the transmission of the disease. And so we have people within the community of the Health Science Center that hail from countries really all over the globe, but certainly some of the endemic areas that were in Dr. Bowling's comments. And so we've had some people that have been affected by the disease, and going home to visit their loved ones during holiday season and that sort of thing. Those travel restrictions were expanded yesterday, essentially prohibiting international travel for at least the next 30 days, possibly longer depending on what the world state looks like over the next 30 to 60 days. That if you've completely glazed over everything that Dr. Bowling and I have said today, if you can recall the second bullets on that list, right now travel should be considered a high-risk operation. Any travel that members of the Health Science Center community are doing right now has to be a mission-critical or life-saving type of adventure. We do have people that work in organ transplantation that are literally working to save people's lives, and some of that work may have to continue on and may not occur directly in San Antonio. So some of those things, we do have a methodology to work through the deans and the president's office to get approval for those kinds of things. But I think you're going to find that most kind of secondary or support travel, like continuing medical education or other kinds of scientific endeavors, I think you're going to find that most of those endeavors are canceled right now, and really are not the sort of thing that we should be doing. You'll find that many large gatherings will be canceled. Most medical conferences over the next 60 to 90 days have already been canceled and will be canceled if they're not already. So most of those things will be probably denied over the next 60 days. So I want everyone to be prepared for that. And I recognize that is a significant change. It's certainly something that if you had asked me about this on January 1st of 2020, I probably would have thought you were crazy. But it is where we live and the risks that we face right now in March of 2020. When you look at the case maps that Dr. Bowling mentioned, I think you're going to see an increase of cases, especially in Europe and Western Europe particularly. You see a large increase in those cases. So it's possible that some restrictions may even increase to include domestic places. There are a couple of places stateside where there have been some community transmission, particularly in Washington State here in the United States. And so there may be some additional things that we have to do domestically. So really all domestic travel needs to be thoroughly reviewed and probably put in abeyance for probably the next 30 to 60 days. And I recognize that that's an unpopular statement and an unpopular decision, but it is something that we need to work through right now. I would urge you to talk with your chair of your department and your dean to work through any of those issues, and really we need to do it now. Secondarily to that, this is the season where a lot of people have personal travel for the holiday season at spring break, and obviously the Health Science Center cannot regulate personal travel, but we have created a travel tracker log to allow you to self-report your personal travel, and then we can follow up with you if there's any kind of needs for additional symptom screening or possibly even isolation, if depending on where you're going for your personal travel. So the President's office is going to send out communications to give you additional information on that. We'll probably have that out in the next couple of hours via email. So look for that, and it is a safe, secure place, literally just to indicate where you're going and a little bit of data about the dates that you'll be there. Let's go to the next.
I might just add, Mike, just to clarify, again, there's going to be more guidance coming from the President's office later today, hopefully. But I think it's also important for travelers to realize that business travel that has already been approved is being reviewed as well. So even if you were approved for travel, that needs to be reviewed, or will be reviewed by your supervisors, and so you need to contact your supervisor to confirm that decision.
Okay, thank you, Tom. That's an excellent point. There's a couple of those travel advisories that are on there. I'm not going to list all of those, but essentially there's different warning levels. The higher the number, the more significant the risk is for community-based transmission. Those all come from the CDC. I don't want to enumerate them all right now because honestly they change at literally an hour-by-hour basis. So on the Health Science Center's COVID-19 website is a link to the CDC's website, and they're very good about updating that information. So I would urge you to go straight to the CDC source on that. Here, and I already sort of unveiled it a little bit, but the Health Science Center does have a very good SharePoint site with a fair amount of information about this. It has information from Dr. Henrich himself and his concerns. His foremost concern is the safety of you, the safety of our faculty, staff, and students. And in particular, our patient population. We have a variety of different patients that would be highly suspect to or susceptible to this particular disease. And so Dr. Henrich has really urged us to consider all of our deliberations to include the impact that this would have on our susceptible populations. And so that is the website that you can go and visit. It's relatively easy to find just by searching through the name COVID-19. We also do have a Ask the Expert email address. It is covid-19 at uthscsa.edu. In fact, the people that answered that email are all sitting at this table right now. So if you ever wanted to speak with us directly, that's a great way to do it. And also you can certainly call Environmental Health and Safety. We will work as best we can to follow up directly with you and your department. Our friends in Human Resources really wanted us to start thinking as an institution about what we might be able to support the essential functions of the Health Science Center through telecommuting. And if you're not familiar with that concept, what that means is essentially doing your work on behalf of the state of Texas from your primary residence, and using a lot of our computer and networking tools in order to do that. Our IT folks really work tirelessly to secure our networks so that we can use these tools. And so one of the things that you can do right now to test whether or not you have that capability is to go to your home network, go to your residence, and download what they call a virtual private network, sometimes called a VPN. And that system will allow you essentially to seem like you are on campus. So it's like a direct connection to the Health Science Center's network, and that requires some authentication, like a double authentication in order to do that. But once you're set up, it's just like seeing your files, just like in your office. There's really no difference to it. It's a very secure way to do that, and you can access normal applications. I prefer to do it with a laptop, but you can actually do it with the desktop if you have a desktop at your residence also. The other thing that you can do is you can actually take your work desk phone. So if you're fortunate enough to have a desk phone, you can actually forward that directly to your mobile phone. And we have a lot of folks that really don't have normal office hours, and so they routinely forward their phones to their mobile phones. Let's go to the next one and talk a little bit about Jabber. The Health Science Center also has an additional feature, which is kind of like a chat feature, and you can actually see my name there. It's called Cisco Jabber, and it's a chat client that the Health Science Center has, and it allows. So, for example, if Jason Bowling and I wanted to have a conversation electronically, we didn't want to just do it via text messaging, or we didn't want to do it via email. You can actually do the exact same thing with Cisco Jabber. It literally just pulls up a chat box and it pops up on Jason's desktop. He can answer whatever question I have and hit the send button. It's really the same as text messaging, really. You can actually call using your phone, using your computer, just like a phone, using Cisco Jabber. So it's literally just a kind of a replication of the calling and texting feature that you probably already have on your telephone. It is a standard installation with Health Science Center computers, and it is currently already available. You can see there's a whole lot of folks that are on that list, so you can see there's pretty widespread usage of it at the Health Science Center already. This is just kind of a short list of some of the things that this group of panelists has been doing the past probably 60 days. We meet on a regular basis with both faculty groups. I meet with departments almost every single day. I'll do a lecture or two for departments that are concerned about the impact of the COVID-19 on their department. And certainly if you have a need for that, I would urge you to email us. I'll show you our email address here again in 1 second. We have also had another town hall meeting. We had an actual live together town hall meeting right before Valentine's Day. We wanted to have this meeting in a virtual state, really to demonstrate to the entire Health Science Center community that we take this seriously, and that our ability to distance socially like this is something that we want to do to protect you and to protect our patients. And so this was our first, I think the first ever virtual town hall meeting we ever had at the Health Science Center, so this is kind of a new way of doing things for us. We also have an overarching working group that Dr. Henrich and Dr. Leverance both lead, that helps us guide us in some of these safety principles that I already alluded to. Furthermore, we have an emergency text messaging system called HSC Alert. You should have received a message from the HSC Alert on Valentine's Day. So if you love someone, make sure that they're enrolled in the HSC Alert system. It doesn't cost anything. It's literally just a one-way text messaging system. I'm hoping that you have already received text messages from it, because we do use it when we have other kinds of emergencies. And this would be a system that we would use to make certain important announcements, especially things that are very time sensitive. Let's move to the last slide. Then we're going to open it up for some questions to everyone. I just wanted to reiterate to everyone this last. There's a chat feature. If you have a question, put it in the chat box and let us know. If we cannot answer it right now, we will follow up and we will post it to the Health Science Center SharePoint site on this subject, and we'll also follow up with you directly too. Here's the email address if you prefer to follow up privately via email. We would be happy to do that with you that way also. Okay?
Good.
Let's open it up for some questions now.
Okay. So panelists, our first question, let me scroll back up to the top. We've got a number of questions coming in. Okay, first question is, do travel restrictions only include air travel, or is this inclusive of other forms of transportation, such as car, bus, or train?
That's a good question, and I get that question often. Obviously, the social aspect of airplanes would be similar to being on a bus or perhaps other kinds of transportation of large numbers of people. Primarily, the risk, the past risk has been international, and so there's not very many bus rides that go from here to Wuhan, China. So the past few months, we've really been focused on airplanes. Obviously, there are now cases, community spread in the United States, and so we may need to look at some of those mass transportations, let's say to other parts of the United States. Our primary efforts the past week or two have been to international air travel, and I think you'll find that's probably the biggest risk factor for transmission, at least the past 2 weeks.
I would agree. I think that it is important to recognize this domestic travel restriction for mission critical work, at least at the present time, and it could change, is for out-of-state travel. It could change for in-state travel, obviously with newer cases reported in Texas, but as of now it's considered, I think,
less of a risk.
Out of state and less of a risk.
Okay, I think we all agree on that. That's an excellent question, though. I mean, obviously, that tells me that this person is thinking about the respiratory droplet risk.
Right.
For sure. So that's an excellent question. Good inference.
The next question has to do with traveling to conferences and if that's going to be restricted for the next month.
I think the answer to that should, without a doubt, be yes. I think you need to think long and hard about travel in general terms. If it is a conference, especially an international conference, I think that's a hard no unless there's some very extraordinary circumstance with it. And if it's other kinds of conferences, scientific, and I recognize the validity of those scientific conferences, I think you need to think long and hard about those kinds of things and work through your department chair and your dean. I think that the general answer is going to be that those things are at least put in abeyance for the time being.
And I think the reason for it is, as Dr. Bowling said, and pretty clear, that's been most of the transmitted disease in the U.S. that has come back has been from travel related. And so I think especially large gatherings, even if they were in the U.S. but included large numbers of international people, then you have to be concerned about that. And even if you go to areas in the U.S. that are active in terms of community transmission, like Washington State, probably Oregon, and certainly California, where they have a health emergency, that needs to be reconsidered.
I agree.
The next question has to do with departments hosting large events and if you can provide clarity on the rules regarding hosting those.
I think that's also a moving target as of right now. The health department, this is an institution, but the health department in San Antonio is not recommending the cessation of larger groups. I think what you've heard, though, from the two presenters, though, is you have to be very cautious about those events, because those kinds of events are ways that we end up with disease spread, and that's why we're having the virtual town hall.
Right. And part of what we're doing as an institution, just to kind of tail on those remarks, we are going to move most of our kind of medium and size meetings from our patient care areas. So, for example, we're moving as many meetings out of the Mark building, out of the cancer center, as we possibly can, and having them virtually, similar to the meeting that we're having right now, or perhaps canceling them if we can. Or moving them to a non-patient care area. We take this very seriously, and I cannot tell you how important it is for you to just rethink the need to have some of these. And I'm not saying that we can't have them eventually. I'm just saying that right now, during the midst of this crisis, we need to take a long, hard look at some of these measures and see if there is a different way to approach it. And that's really what I'm asking you to do.
And the president's email from himself said that he had canceled two very popular events that were coming up, the presidential awards and the presidential council. So I think it's an important example.
Yeah, very important. It's a dynamic situation, and we know that the numbers are increasing right now. This is a kind of a fluid situation, and so proactively moving away from being in these congregate settings where you're going to be exposed to people that may not know that they're potentially an exposure hazard. This is the way to kind of proactively get away from some of that and decrease the risk. Really, in this, we're trying to prevent and slow community transmission. We don't have any documented community transmission. We don't want it, but moving away from these mass events is a known way of decreasing transmission, and so it's a proactive way to try to protect everybody.
Yeah, so as a health science center, we really want to be at UT Health, San Antonio, we want to be ahead of the curve. We want to basically be proactive about the decreased community transmission and not wait until we get community transmission and say, oh, wow, we should have canceled these events.
That's right.
Yeah. Good point.
And on the same lines with the email that was sent out by Dr. Henrich regarding the international travel and domestic travel, they're asking if an email will be sent to the UT Health community stating that travel should be mission critical and life-saving in nature.
Yeah, we will work through the President's office to send out some additional information. So that's an excellent point.
And so from UT Health itself, Dr. Leverance, right before this town hall, did send those words in an email and to point out to that the reviews are really ongoing and in place.
Okay.
I believe we may have answered this already, but the question is if the ban is only for air travel or all travel outside of San Antonio.
Yeah, so right now there is no ban on domestic travel. But that is very much subject to change. It literally could change day to day. So right now, on Friday the 6th, that is true. But you need to significantly review all domestic travel, no matter the location, and rethink whether or not it's appropriate during this crisis situation.
Next question has to do with the infrastructure for Jabber and for forwarding phones to mobile devices and whether or not there's sufficient bandwidth, connection, and just infrastructure to support telecommuting.
Well, that's an excellent question. I'm not sure the three of us are the best at answering that particular one. If it's okay, we will. If you have questions, kind of questions about the mechanics of how this all works, we'll follow up directly with you or your department chair and see if there's a way to work through some of those things. We're not super knowledgeable about each individual circumstance like that.
It's obviously a good question, and we'll definitely put that answer on the facts, the frequently asked questions on the SharePoint site. So we'll make sure that the persons who can answer that question do it.
And actually, Tom's point is very well taken. If you don't know, why don't you go home and test it? Let's spend a little bit of time, maybe this weekend or tonight, just see if it works. And that would be time well spent, and that way we'd have some level of confidence that if we got to an emergency situation, we would have some abilities.
Right, and testing it out would also be good because if you can't connect, you may need help from support. You can get it done before you need it. So testing it now kind of be proactive again.
Yeah, so you can make sure your own connection, at least individually, works or not, and then we can ask the question institutionally, are we ready for this?
The next question has a few questions within it, so let's go ahead and break this down just a little bit. It has to do with individuals who are currently on travel and might be returning later next week or even the week after, and whether or not their coworkers will know if this individual needs to self-isolate themselves, or how will they know that this individual has been cleared to return to the office setting?
Good question. Everyone that is traveling on state business, that goes through an approval process. So we have a very tight list of people. We know exactly who it is that's traveling, and we're reaching out to those people. Anyone that's traveling to an endemic area would probably have to go through that 14-day isolation period. We've had a number of people in the Health Science Center community that have had to go through that. People that are not going to an endemic area more than likely would have to go through a period of symptom monitoring for 2 weeks, where they twice daily monitor their symptoms, record them on a spreadsheet. At the conclusion of that period, they have a consultation with a medical provider. Normally it's with the employee health clinic, to verify that they've successfully gone through that process. So there is a kind of approving or a clearance process for anyone who goes through either of those processes. That's a good question. We wouldn't necessarily post a person's status anywhere, but there would be an approval with the supervisor to essentially make sure that they're clear for return to work situation or return to school. Good question.
And some of that will clearly change, so we're going to get that reviewed by the appropriate persons at the Health Science Center, so it could well change, and some of the guidance from the CDC and the Health Department would suggest some people may need to return to work in certain settings and do this monitoring and not quarantine, but it'll also relate to where you've traveled.
Our next question is with regards to residents and fellows who are requesting to travel domestically for vacation, and whether or not that travel should be discouraged, or what type of guidance should they be giving to those individuals?
It's very similar to what we were just talking about. Obviously, for those of you that don't, many of the residents work in an inpatient facility, work very closely with our patient population here at the Health Science Center at University Hospital. And so they need to work with the resident office and the chief resident in their area to make sure that that's been properly vetted. More than likely, they would have to go through a period of symptom screening for 14 days where it's recorded twice daily. If it's an international person that's going to an endemic area, it would be very similar to what I just said. That person probably would have to go through a 14-day isolation period. We had one resident that had to go through that period already here due to a travel history. So obviously the importance of travel and the impact to patient care is significant, and I can't overstate it.
And we have another question, again, just clarifying travel and whether or not the domestic travel ban only applies to out-of-state travel. For instance, could someone fly to Houston or drive to Brownsville?
Okay, since I was the one called out as saying it, I'll have to take that. So again, the guidance is this is a rapidly moving target, and we will receive more guidance and clarity from the President's office. That statement was based on the fact that we don't have community transmission in Texas yet, but I know there are large groups gathering, like South by Southwest up in Austin, that there's a big discussion over. So it may well change, and so I think any of these advice statements are really something you've got to continue to review with your supervisors, your chairs, and the dean.
Agreed.
You guys want to comment?
Yeah, I agree. In the end, I think we have a recurring theme with this, in that, as Dr. Hendricks said, using the common sense principle, looking at where somebody's going to be going, how long they're going to be there, recognizing that things may change, even if they're in a place that looks safe right now, that could change. And so we want people to self-disclose, to use that database so that we can be aware of where people are at, because you may be going to a place that right now looks fine on all the maps and trackers and data, but if they're there for a while, that could change, and when they come back, there might be different recommendations for what they need to do when they return. So everybody needs to be aware if they travel, the recommendations for what they do when they come back might vary. And we'll be following that closely and working as well as we can with all the supervisors to make sure we have good, safe, and consistent return to work policies. But some of that consistency is going to be modified by the variability and kind of things changing, number of cases.
For sure.
So what's good today may be different a week from now.
For sure.
And just so attendees know, we are answering questions as they are coming to us, and we're going down the line as questions are listed. The next question was regards to travel to California, but I believe Dr. Bowing's advice still follows suit with that. And then another question is, if travel was already booked and cannot be canceled, like hotels, will people still be reimbursed?
Well, we probably could still cancel. I mean, there are probably financial ramifications for a very late cancellation. When we first sat down, Dr. Patterson and I were talking about a medical conference that is going on tomorrow that was canceled by the host institution today. So there certainly is some ability to still cancel it, even if we do have some financial capital outlay to begin with. My general response to that is I'm not really sure that Dr. Patterson and Dr. Bowling and I are the right ones. I would urge you to talk with your administrator or talk with your department chair about the financial implications of that versus the risk of attending a large medical conference right now, and work those two things together. I hope that you'll get a sense of our concern, and that it is a very overarching concern for your operations in your clinic or your operations in your area. So please do take that into consideration when you have these conversations.
I mean, I think unfortunately it doesn't make it mission critical because you've already registered. We hope that having, institutional disapproval of a travel would make it somewhat easier to get refunds of registrations in hotels or whatever. But obviously that has to be worked through with your supervisor kind of on an individual basis.
Sure.
The next one is with regards to international travel. If coworkers know that their coworkers are planning to travel internationally, what can they advise regarding this concern?
That's a good question. We've had a few situations similar to that question that have occurred already in 2019 where we had other people traveling to endemic areas, and there was some concern from coworkers that worked with them and were aware of their travels because they're obviously friends. I would definitely urge you to work directly with the employee or work with your supervisor. We would very much like that information to be self-reported by the traveler themselves. We don't want anything to be punitive or anything like that. This is a collegial medical institution, so we want this to be very professional. So I would work through your supervisor as best as possible on that, and just urge that person to self-report that. This is not intended to be anything that's punitive, so we want to work with that person so that we can ensure the safety of themselves and the rest of the people in the clinic or the lab.
And it's also important to recognize, to add on to that further, that the situation is changing, and it's important for people to recognize that traveling internationally, they may end up at a place that if travel gets restricted back to the United States, they could get into real trouble. Not only from the risk of their health of being exposed to the COVID-19, but also just being able to get back. And there have been people that have been delayed in their ability to return. So depending on where you go internationally, there could be some real issues, not only with risk of getting exposed, but also being stranded for a longer period of time than you initially intended. And so anybody that's traveling internationally right now needs to recognize that with this dynamic situation, things could change on them, and you may have alterations in your planned itinerary.
Good point.
The next question, is it feasible to test patients for COVID-19 at a clinic when they present with fever and respiratory symptoms, but have no known travel or known contact with individuals, yet they're demanding testing?
So I would say that for testing right now, again, this is going through the health department, and they're really relying on pretty strictly defined criteria for who gets testing. And if someone doesn't have a known exposure and they're not being admitted to the hospital, they're not going to be providing testing for that. It would be important for them to obviously be evaluated clinically, and it would be recommended that they be tested for other respiratory viruses that are still circulating right now. We're still seeing cases of influenza A and other respiratory viruses that are not only causing people to be sick, some people are being admitted to the hospital with these. And so, but testing for COVID-19, unless they meet the public health definition right now, is not being performed. And so that's what the provider needs to relay to somebody presenting for care.
Yeah, so for those attendees that do have a clinical role at the Health Science Center, there is just a limited throughput of testing currently in the United States. There are many health departments, both state and local, that are trying to expand their testing. The Health Science Center has some laboratories that are working to expand our testing capabilities here also. But those things take time. Obviously, diagnostic testing and vaccines both have to go through an approval process that can be a little bit laborious. So this testing is really limited to people that have very specific risk factors right now.
Right.
So,
The next question has to do with sterilization of the clinics and who will be responsible for this.
that's a good question. Generally speaking, clinical areas are done by the clinical employees on a day-to-day basis. If it is something specific, if we had a patient that presented at one of our outpatient clinics, like a primary care clinic or something like that, we have a very specific procedure for the types of protective equipment that the staff would wear, that the provider would wear, respiratory protection, and gloves, and eye protection, very important. Then the most important thing after that is we would close the door and leave it in a static condition without additional people in there for probably 4 hours, let the ventilation system work its magic, and then we would go in and go through that cleaning process. Dr. Bowling did allude to the fact that the primary risk factor is really respiratory droplets, so if we can restrict the area from other people being exposed to respiratory droplets, we probably have eliminated most of the risks, but there could be that environmental risk of horizontal surfaces So we do have the capability of using viricides, EPA-listed viricides, to wipe down horizontal surfaces. If it's something large, multi-buildings or a large part of a clinic, we do have an environmental restoration company that we use that is actually did some of the work at North Star Mall. So we have a vendor that we use that can also do large areas if we really got into a very difficult situation too. It's a good question. I don't get that one very often.
And again, the disinfectants we use for influenza are effective against coronavirus as well. So really, standard practices should be effective.
And a related question to that is with regards to dental, who is in an open floor environment, and what precautions should they continue to take, especially with hand pieces that might be cleaned using aerosol pans?
That's a good question. I can tell you that Dr. Gary Guest, who is the chief over the dental outpatient clinic, is part of our working group and has been a robust participant in that process. I think he understands what their risk factors are and kind of how they can manage those risk factors. I think Dr. Guest feels that health history evaluations when a person presents is critical. I'm speaking a little bit for Dr. Guest. I guess I would urge you to talk directly with the clinic administration and work through those issues with them directly. But I do think they feel like if a person's not healthy enough to have dental care, we could probably wait a sufficient period of time until they are healthy enough to go through with their procedure. But I would urge you to talk with the clinic administration on that one. Good question.
But I think our patients at the mark and throughout our practice is basically, the script is basically to clearly ask about travel history, about flu-like symptoms, really from all patients. So if you're a patient, you'll get that question. As providers, you're going to be asked to give that question.
Right.
Next has to do with recruitment. If someone's being hired and their visa is already processed, will we be able to onboard them?
That's a good question. I would urge you to contact the Office of International Services, OIS. Our international community is very well served by all of our internationalists that work in the OIS. They have a really good gift on being able to work through that process. I know there are many different types of visas that are available to people. I think in general terms what's happening is people that are hailing from endemic areas are being deferred for a period of time. So that does not mean that they can't come. It just means they can't come right now on March 6th. So I think as Dr. Patterson mentioned, it is a dynamic situation. I think some of those things will be cleared up with time. But I think when it comes to the visa process, starting early on with the OIS is really your solution. Those are really the people that will help you navigate that system. Good question.
Next question is, if a provider is over age 60, what additional precautions should they take when interacting with patients?
I could let Dr. Bowling answer that, but that may be applied to me more. Maybe I should answer that. I think that you should recognize the providers are clearly trained in the precautions that are recommended and necessary. That's also probably changing as we know more about the pandemic, but those standard precautions are in place and hopefully we're all trained to use those the protective gear. And so no, I don't think they do something different, but I think they do the same. Yeah.
At this point, is telecommuting being deemed a recommendation or requirement?
That is not a requirement by any stretch of the imagination. That is something that we want to get prepared for. If you have the capability of doing that and your department can support that, this would be a sensible time to try to work through those issues. But that's not a requirement by any stretch of the imagination, no.
And again, testing it now, if some of these things, if you want to test to see if you have the capability to do it, looking at it,
I agree.
as Dr. Charlton said, would be a great way to kind of know now why it's not a requirement, so that moving forward, if that were to change, you would be ready to go.
Well, and I think all of our departments, this information also came out from HR to talk about in a serious way, cross-training people to do work, to make sure what your mission critical people are to come into work, who could do telecommuting. But again, to proactively plan and not have the crisis set upon us. Sure. I think that's why Mike showed those slides about that possibility.
And our friends in IMS, which are our computer IT folks, they do have a web page. I believe it's called Telecommuting 101 with just kind of the basic functions of how you would do this. I think if you search through that through the Health Science Center SharePoint site, you'll be able to find that. And it'll have some of the similar information that we just went through here in our overview slides. Good question.
If somebody comes down with the flu or a cold, what is going to be the biggest red flag that they should be tested for corona?
Yeah, so that's an excellent question. So and the answer I will say is going to be very unsatisfying because the symptoms are not going to be enough clinically just by asking what symptoms they're having. The travel history might be more helpful, or if they have known exposure to somebody that has documented COVID-19, then obviously it's going to raise your level of suspicion for that. Otherwise, really you're not going to be able to tell by symptoms alone because you're right, they do overlap. There's a lot of non-specificity to all the respiratory viral infections. Fortunately, the same preventative practices work for all of these as well. And so that's why there's a lot of focus, an important focus on hand hygiene, social distancing, covering your cough, staying home if you're ill.
But we do have tests to look for flu, so that's why your primary care provider will likely want to test you for influenza and other respiratory pathogens, maybe even through molecular test, and we do have that available. So that helps us sort it out. It doesn't mean you couldn't be infected with both, but it's less likely.
I do want to recognize that it is 1:30, which was the original end time for our webinar. We will continue to take questions, but we realize that some of our guests will need to drop off the call. So we definitely want to thank them for joining us, and we will continue the question and answer session.
And we will post all these. We can go through the questions that we don't get to and answer them offline and post them on our SharePoint site, right?
Yeah, we'll follow any question either that we didn't answer sufficiently. Jennifer Meek has been here scribing furiously for us, and she will help us transcribe all those things and make them available, even for those that had to leave earlier, people that were unable to attend today. So we will follow up, as Dr. Patterson mentioned, we'll follow up.
And if you want to, again, take advantage of the COVID-19 at utusca.edu site, we will also answer your question individually.
Sure.
The next question has to do with leave. And if someone is put in home isolation, what type of leave is going to be required?
That's an excellent question. My general response when people ask me that question is to talk to your supervisor, and your supervisor should talk with your HR partner and work out the leave details for that. We have had a fair number of people that have gone through that, and they were actually able to work from home. This is a great time to update your CV. This is a great time to work on a manuscript that you've been meaning to work on for a long time. There's a lot of things, a lot of training things, continuing education-wise that we can do and make beneficial work from if we do fall in that category. So just work through that with your supervisors and your HR partners. Our HR team is very talented and really has a good way to help our supervisors on that question. That's a really good one.
And the next question is similar in the sense that if somebody does return to work, or rather they're preparing to return to work, and they have a fever or they are feeling under the weather, what type of judgment should they use for themselves or communication with the supervisor as they prepare to return to work?
Well, I'll take this one, although this is more of a medical question. If this person is ill, this would be no different than if you had asked me this question 5 years ago, right? If you're not sufficiently able to work on behalf of the Health Science Center, I would urge you to stay home until you are sufficiently able to work here. This particular disease does not necessarily change that. So if a person is exhibiting symptoms, let's say of a fever, we need to make sure we get seen by a competent medical professional and sort of find out what it is that's causing that. And so that I think before we come back to work, we need to go through that process of working with the person that you already have a medical relationship with.
Yeah, and for domestic travel, returning from domestic travel, there's largely right now in the United States, there's several areas that don't have much documented cases at all. But there are other areas that were mentioned previously, California, Washington, some in Oregon as well, where they're seeing some community transmission. And so there's some areas that domestically that have more cases, and so might pose more risk. And so some of these recommendations, again, we're following on a regular basis to tracking the number of cases to see what potential exposure risk is, to see if we need to modify recommendations.
Sure.
The next question is whether student meetings or events need to be canceled at this time.
I think Dr. Patterson alluded to organization, large meetings in general terms. Specifically for student meetings, there's no current requirement either by the state of Texas or by our local public health officials to stop having large gatherings. I think if it is something that we can easily accommodate, say several weeks from now or a month from now, I think we should think through that. We do have some very large gatherings that are very difficult to reschedule, so we understand that. I would urge you to just use normal precautions, hand hygiene precautions that Dr. Bowling mentioned, as best you can, and try to avoid that as much as possible. But if it's a smaller meeting, if it's, let's say, a student group that's interested in cardiology issues, if we could move that to later in the semester or just cancel it altogether, that's probably a prudent course at this point.
The next question is with regards to protocols to follow if someone is expecting visitors from areas with higher exposure, such as Seattle or California.
Right, so obviously I can tell that this person has been following pretty closely news and current events, because those are areas of concern in the United States where they are seeing some transmission. And so we would need to treat those areas, someone being a little bit at potential risk, and likely they will be on self-monitoring for a 14-day time period on a return, on arrival here. 14 days counting from when they return from those areas, Seattle and parts of California. California's declared statewide health emergency because of transmission there.
Right.
I think at the least the person needs to be aware of them being free of symptoms. But again, as the other two speakers have said, if those persons could have their visit delayed, it may be something to consider.
Right.
The next question is with regards to student-faculty collaborative clinics and what clinic hygiene procedures need to be followed.
I don't really know what the faculty collaborative clinics are, the student-faculty collaborative, but all of our clinics are following these same sort of precautions. So
Let's take one last question, and we will wrap it up from here. If you did not get your question answered, please, I would urge you to follow up with us. We would be happy to follow up with you via email. You can call us also. Just use the COVID-19 email address, and we will work through all those. And as I mentioned, we will take this presentation that we did. Our HR team will work fast and furiously to put it all together, and I believe they're going to put it on their own HR YouTube channel. So you'll actually be able to see Dr. Bowling and Dr. Patterson on YouTube here probably later today or tomorrow. So if you want to go through it with your department at a later date, that's another time to do it, right?
And so our final question has to do with individuals who already are involved with using bloodborne pathogen precautions, and what additional supplies or procedures should they implement in their areas?
So I think the clinic has been working on providing education to the staff about how to handle a person that would be concerning for having COVID-19 disease, and so they need to be moved to a private room. There is specific PPE that's used for this, and it's gown and gloves, and currently an N95 mask, although that's subject to change hopefully soon, and eye protection. And so the clinic staff have been working on how a provider would be able to enter the room safely, to ask the patient questions to see if they do meet the criteria for being a person that has suspected COVID-19 disease.
Sure.
So that is our final question for the session. Any additional questions should be sent to covid-19@utesca.edu. Just as a reminder, today's webinar is being recorded and will be available on the HR YouTube channel later this evening or early evening. And an announcement will be made on the COVID website and via email. And we want to thank everyone who participated on today's webinar. We want to thank our presenters, Dr. Bowling, Dr. Patterson, Dr. Charlton. We want to thank Jennifer for scribing and documenting all of our questions that have been presented today. And this concludes today's webinar. Thank you.
thank you.
Thank you.
Thank you.